time, we'll go ahead and start. So good morning, thanks for joining PCEP case reviews for November. My understanding is that there will not be case reviews for December, so you'll get a month hiatus, but there'll be plenty of good material to cover for January. So moving forward, confidentiality. As always, this information is privileged and that we really want to respect the patient's information and their privacy, as well as the providers that were involved with the care, unless they would like to volunteer their involvement. So for case one, 54-year-old male. This picture is supposed to represent how weak he was as his chief complaint of shortness and weakness. PPE used included a HEPA mask, gloves, eye protection, and gown. He was noted to be alert, oriented. His airway was open, but it was obvious that he was labored in his respirations. His pulse was present, and there was no signs of bleeding. Initial vital signs obtained a few minutes after patient contact was notable for a heart rate of 113. Tachypnea at a rate of 45, no SpO2 was recorded, and that he was an average-sized man. Past medical history included a stroke on anticoagulation, as well as non-Hodgkin's lymphoma. And the history provided was that he's had 3 weeks of flu-like symptoms and weakness, that he had a sudden onset of shortness of breath with exertion, which I believe from the documentation was what prompted the wife to initiate 911. Of note, he had no complaints of chest pain, abdominal pain, back pain, numbness, or tingling. I changed the format with the time so that it actually, instead of the actual chronological time, is more of like a time from being 0 minutes. So upon arrival, fire department was standing outside with a single provider inside. In the warm zone, it was advised that the fire department paramedic in charge will advise of any additional necessary resources. The patient was contacted, peripheral IV was established, and he was placed on 2 liters nasal cannula. A 12 lead was obtained a few minutes after patient contact, as well as a blood glucose, which was a little bit elevated. And his initial 12 lead was obtained 6 minutes after patient contact. Just make sure I'm not missing anything. So this is his 12 lead. Obviously concerning, he's tachycardic, but what really stands out is this ST elevation in the inferior leads and reciprocal changes in the lateral leads, 1 in AVL specifically, as well as what might be a little bit of ST elevation in V3, V4, but there's too much artifact to be certain. You do see some ST depression in V2. So after that 12 lead, a little bit of fluids were given. STEMI activation was initiated. Another repeat set of vital signs was obtained. Now at this time, he's more tachypnic, still tachycardic, in that he is hyperventilating in the sense that his end tidal is only 12. They leave scene 15 minutes after patient contact with a first SpO2 of 50%. So they move him up to high flow non-rebreather at 25 liters per minute. And then looking over to the right-hand side, of note to add is that they obtained a V4R lead, and it was concerning for possible right-sided MIs. Therefore, no nitroglycerin was administered, given concern for profound hypotension, and that he was allergic to aspirin during their history obtainment. He had a repeat 12 lead obtained, showed no change in that, so I did not put an image up for you guys. He was otherwise stable, still a little tachycardic. Pressures were not as soft, or actually a little bit improved after that 250 of IV fluids, and that he continues to be tachypnic. His GCS is normal, and that they take another set of vital signs. Now his SATs are up to 84%. And his end tidal is improving a little bit as well. And after 24 minutes of initial patient contact, they arrived to the hospital. All right, so After just reviewing the information of care provided and documented in the pre-hospital setting, I thought that this crew did a fantastic job of recognizing that this patient had symptoms that were concerning for possible COVID, in that they utilized the COVID Southwest County guidelines that we've been putting out with having, in fact, this is the first time I believe that I've read any report that has talked about, the documentation has talked about warm zone and hot zone and actually utilizing that. I'm sure that all of us have been, but this particular crew documented it. They obtained a 12-lead EKG early on, even though the patient never complained of any chest pain, but concern for a chest pain equivalent, and noted that he had what appeared to be a STEMI. They astutely recognized that that STEMI represented a possible inferior infarct and also checked for RV involvement or right ventricular involvement. They recognized the contraindications, not just the allergies, but also the fact that this patient would be potentially disastrous if they gave him nitroglycerin, and they activated a STEMI alert in the field early on. Some of the things that I think that could be improved on is that in the documentation, we typically document what the contiguous leads are and the reciprocal changes. I don't know if there was an error in the documentation, but it looked like an inferior infarct, and I believe that's what the crews were concerned about, given that they checked our V4R, and that the reciprocal changes were more in the lateral lead. So we should be documenting where the reciprocal changes are, or document that there are reciprocal changes. And then an earlier SpO2 reading, if you guys recall, it did occur a little bit late in 15 minutes, but if you think your patient looks particularly profoundly hypoxic, you don't necessarily need to delay in initiating care. But the only thing is, if we could have gotten an SpO2 when we got our first set of vital signs 9 minutes after patient contact. So in the emergency room, he was intubated. He was sent up to the cath lab and underwent a heart catheterization. They placed a stent in his left circumflex due to occlusion, and he had sustained cardiogenic shock following the heart cath, requiring both pressors and inotropes. On hospital day 2, he developed AFib with RVR, as well as recurrent VTAC and torsades. CPR and defibrillation were provided, and ROSC was obtained, but they were unable to get him out of his AFib with RVR despite cardioversion or medical management. He arrested again, and his arrest was bradycardia that degenerated to PEA. They were able to get ROSC. Post-ROSC, they noted that he was hyperkalemic and treated him for hyperkalemia. And then he arrested, unfortunately, actually should be a third time, where his wife arrived at this point and stated that she didn't want any continued resuscitation given his grave condition, and he was pronounced dead. So I thought that this would be a good opportunity. Recently, the nurses at Peace Health were doing some kind of CME, and they were talking about V4R. And we have a great case here with V4R and its importance. I thought I'd reiterate for those that already know about it and any of our listeners that aren't familiar with V4R. So up to 40% of MIs that involve the inferior aspect of the heart involve the right ventricle as well. And that the right ventricle is concerning when there's impairment in its function, because it's pretty much, it's very preload sensitive. It's very sensitive to if it's not functioning properly, you really have to be careful about decreasing the amount of blood coming back to the heart. And that if you do find that a patient's hypotensive with a RV infarct, that we should be really considering a little bit of IV fluids to try to improve their preload before necessarily going straight to pressors. So how do we detect an RV infarct? First, you have to think about it. So any of your inferior infarcts, we should be thinking about possible RV involvement. We might have a better understanding or a better idea that they may be having a RV infarct if they have ST elevation in V1, or if you see greater than in lead 3, greater ST elevation than in lead 2. You can put on right-sided heart leads, as this image would represent with V1, and then continuing that same mirror image onto the right side as you would do on the left side. But I believe that our protocol says to do V4R specifically. And although doing V1 through V6 right-sided isn't necessarily wrong, if you're going to use the view that's going to be the most sensitive and specific and not waste any additional time in determining if your patient has an RV infarct, you really want to do specifically RV4, because it has a sensitivity of 88% and specific to the MI of the RV, 78%. And then another plug or reminder for the key performance indicators for Washington in regards to STEMIs. This applies to any patient over the age of 35 that either has chest pain or you're concerned that they're having a cardiac event. So making sure that we get aspirin. This was contraindicated in this event, or in this case, because of the patient's allergy, that we got a 12 lead, and that when we get that 12 lead, we really want to get that 12 lead within the first 10 minutes of patient contact, and that's any provider capable of getting a 12 lead. So if that's Fire and they have the ability to get the 12 lead, or the transporting agency such as AMR or GMR, when we have our STEMIs, we really don't want to be on scene for any longer than 20 minutes. This crew was able to get off scene within 15 minutes. In that we want to be activating these STEMIs in the field, in that we want to be taking them to the designated cardiac center, which all applied and was done perfectly in this complicated scenario. A reminder here of our protocol. I'm not going to belabor the treatment, but that we do and have in our documentation on the right-hand side under E as in Edward, that if there's an inferior MI, we should be getting a V3-4R and a V4R to evaluate for right-sided MIs. Any questions, conversation, concerns? Just looking at the chat on my phone. Don't see any. Give you guys a few minutes. All right. So the next cases are, there's 2 of them, and they're to demonstrate a particular issue or concern. So this one is a 62-year-old female that she was in a car with 2 cars involved. There was a lot of rain, and the conditions were particularly rainy and poor visibility. Her chief complaint included abdominal and leg pain. PPE obtained and worn by EMS was appropriate. Primary surveys that the patient's awake. She's alert and oriented. She was drowsy in that she didn't have any issues with her airway and breathing, but they noted that she had a weak radial pulse. She was pale, she was cold, but she was also outside in the rain. Initial vital signs obtained were concerning for a tachycardia rate of 100, respiratory rate, tachypnea with of 30, no SpO2 and no blood pressure was obtained at this particular time, and she's a little bit of a smaller woman at 60 kilos. Past medical history does not appear to be contributory, in that the history provided was that this was a 2-car MVC, nearly a head-on, or you could call it a head-on, reportedly traveling the speed of the roadway, which was 25 miles an hour, although EMS's documentation was that they believed the vehicles were traveling at a higher rate of speed. The patient was the restrained front passenger. There was no loss of consciousness, and that law enforcement were able to get on scene pretty shortly after the accident occurred, and that they were concerned that the vehicles might catch on fire, so they emergently extricated both occupants out of the car. The other car, everyone self-extricated and placed. So the car where the people were still in, they emergently extricated them out and placed them into the roadway. Unfortunately, or fortunately, this was, as mentioned, a rainy afternoon, so they were exposed to the elements. They noted that there was severe front end damage with airbag deployment, and that there were 4 patients. 2 of them were thought to be critical, and 2 were walking wounded. My understanding is that one responding agency, transporting agency, was on scene and awaiting for more hands and more vehicles due to the MCI. So EMS came up on the patient, the 2-year-old female, and noted that she was a little tachycardic, a little tachypnic. A peripheral IV was established in the roadway, awaiting transportation and more hands. It was obvious that the patient had multiple injuries and would need pain control. But before I go into that, I'm just going to have you guys look over to the right. So the patient had some pain and tenderness over the right jaw. She had shallow breath sounds, but they were present. She was cold and pale. She had a weak, thready pulse. She had diffuse abdominal pain in all 4 quadrants. There were abrasions to her iliac crest bilaterally. There was a closed deformity to her left femur, and there was a closed deformity to her left ankle. So given the multitude of injuries for this patient and the mechanism, the provider moved towards pain control, as there would be time waiting for the transport. So fentanyl was given at 100 micrograms and 2 milligrams of Versed. Another set of vital signs were obtained. Now she's still tachycardic, but now hypotensive, or at least first identification of hypotension at 87/62, and her respiratory rate was 6 unassisted, up or down from her previous 30, and that still an SpO2 is not available. Or actually, still, I should not say still. They had some difficulty in getting an SpO2 at all during this encounter because of reading they thought might be attributed to her cold extremities. So placed her on that she was 33 and that her GCS had decreased from 15 to 3. Assisted her ventilations, and then I don't know if someone's unmuted to ask a question or to provide any additional information. Okay. Transport was initiated 23 minutes after movement to long spine board for spinal precautions, in that she was transported to Peace Health. Her vital signs were repeated throughout the encounter. If you're not going to be commenting, make sure that you're on mute, please. And that her ventilations were assisted with a bag valve mask. Her end tidal continued to be within, for the most part, normal limits, in that they also placed her on 4 liters nasal cannula as supplemental oxygen. At approximately 42 minutes from patient contact, it was noted that she was starting to wake up again. Her GCS was 14. Her vital signs were improved with the treatment that she had received. She's no longer tachycardic, and that her blood pressure is now 110 by palp, and that they arrived to the hospital at 43 minutes from patient contact. So in reviewing the care, I thought that the crews did a great job in trying to triage multiple patients. That this patient that I presented to you guys was not their only sick patient. This was one of 2. Getting an assessment done on her, especially the fact that it was potentially limited because of inability to completely keep her from view of external bystanders, and then initiating care while awaiting resources to transport instead of waiting until everyone shows up, which may make things a little bit even more difficult when you're trying to do that en route, as it's trying to save time from being on scene too long. Quick reaction to inadequate breathing with BVM and supplemental oxygen, and then management of hypotension with respect to permissive hypotension. She's altered, she's hypotensive. We really do want to treat those patients with preferably blood products, which we don't have, so crystalloids, but not doing it as right from the get-go. You want to make sure that you think your patient is hypotensive and in shock. And then documentation of why the SpO2 was not obtained in the use of end-tidal CO2, since there was equipment failure. And then where I think that we can improve is not mixing our analgesia with our sedatives for treatment of pain. So follow-up in the hospital, she was noted to be hypothermic at 30.3 Celsius. She had hypotension at 97/56. She was tachypnic again at 26, and that her GCS was still reduced at 9. Her FAST, which is an ultrasound of her abdomen and heart and lungs, was positive for intra-abdominal fluid. Her physical, she was RSI'd in the department. In speaking with the ER doctor that was taking care of her, they felt that they weren't entirely sure if her altered mental status was related to the gravity of her condition or if it was related to the medications that she received, and that they went ahead and RSI'd her in the belief that she would potentially decline or that her breathing would be an issue. They had said that in speaking with them, they had said that they would have preferred to not intubate it right away so that they could have discussed with her change in condition, but nonetheless, that's what happened. She arrested a few minutes, probably within 10 minutes of arrival. ACLS standard treatment was initiated, a central line was placed, and a thoracotomy was performed by the surgical team. She received intracardiac epi, she was shocked, and they were able to get Ross back. They took her emergently to the operating room. In the operating room, they started a massive transfusion protocol. They found a large mesenteric tear, as well as active extravasation or active bleeding, and they were able to ligate it. They also found that the patient had multiple bowel injuries or perforations, so they repaired that as well with a partial colon and small bowel resection. In the ICU, the patient was hypotensive. She continued to have intra-abdominal bleeding. They had left her abdomen open, so they were able to see the drainage and see the blood accumulating, so they went back to the operating room and further repaired her mesenteric artery. She went back a third time during her hospital course, and unfortunately, they noted that much of her small bowel was dead and that she didn't have enough small bowel to sustain life. They brought her back, and despite the fact that her long-term course with her bowel was very grim, she was also very unstable, requiring multiple pressors, and eventually her husband made her comfort measures and she passed away. This patient had multiple injuries, not just the mesenteric artery, and I kind of did from head down the toe. So she had a breast hematoma, sternal fracture, clavicle fracture. She had a hydropneumothorax, so air and fluid, mesenteric artery injury. She had some multiple bowel perforations. She had a transverse process fracture of L3 and L4. She had vertebral body fractures of L4 and L5. She had a closed femur fracture, a lateral malleoli fracture, and a dislocated thumb. So pretty sick. Case 2B is of a 67-year-old female. She had had a complaint of right hip pain after a fall. PPE documented for one provider was without eye protection, for the other provider was with eye protection. So make sure that you're documenting what you're using, and if not using eye protection, that's minimum PPE need. So primary surveys that she's awake, she's oriented, her airway's open, there's no active bleeding, her vital signs are significant, mostly for hypertension, and that her past medical history includes chronic pain on methadone, as well as a couple other things that are non-contributory at this time, and that the patient was able to relate that she had a mechanical fall because she lost her balance, or she tripped and fell, and that she didn't strike her head, she didn't lose consciousness, and she was not on any anticoagulation. She had vital signs, as mentioned earlier. Peripheral IV was established, and she was given 50 micrograms of fentanyl. EMS documented that the patient was screaming out in pain, crying, begging EMS to help her. When they tried to move her, she swung at them. Patient told him once they got her loaded up in the ambulance that she has chronic pain and that she takes chronic pain meds, and that even those chronic pain meds don't even work for her. So they started transport, gave her 2 more doses of 50 micrograms of fentanyl, and they EMS documents that just prior to hospital arrival, so you can see it's 3 minutes before they arrived to the hospital, the patient complains of severe spasms to the right pelvis, hip, buttocks areas. So they gave her Versed, 2.5 milligrams, and that the patient was noted at the time of transfer, she had a decreased mentation and shallow respirations. The hospital or the emergency room documents that her GCS was 9 and that her SpO2 was 77%, and that she was unable to provide any reliable history, and that they were not sure if the patient was more than just a ground level fall with right hip pain and potentially a head injury with intracranial bleeding, or if this was all iatrogenic or caused by healthcare provider. So in the event to respect that she was a trauma, they initiated a full trauma workup, calling a trauma team down to be part of her care and then pan scanning her. Her only injury was her hip fracture. So I thought that these 2 cases would be a good example of of explaining that we should be really cognizant about what we're managing and how we're managing it. So I think to start off with is the definitions of analgesia and sedation. So analgesia is to take away pain without altering their sensorium or their ability to comprehend the environment. And sedation is, your intention is to suppress their sensorium. So sedation can be just with sedation, or maybe sedation and analgesia combination. One of the things that I want to mention is that although sedation is within the protocols of our paramedic protocols, that we would not be mixing pain and benzos, or analgesia and sedation, benzos or sedation for pain. Our management is very discreet. So we're looking at cardioversion, we're looking at RSI, post-intubation, sedation, and potentially just sedation, just benzos with CPAP to help facilitate that. We really only should be mixing narcotics with benzos only with post-intubation sedation. In the emergency room and also elsewhere within the hospital, we do perform procedural sedation. So sedation with the intention to alter the patient's ability to appreciate the environment, and oftentimes mixed with narcotic management to help facilitate that. And that even though we do that, it's under controlled situations or controlled circumstances. The patient is consented, as this is a voluntary treatment, in that they not only are consented, that they also are discussed what the indications would be for, and also the potential adverse events. And I think that I understand that everything we do has the potential risk for complication, but this particularly is something that I think we need to be really mindful for, because even though it doesn't happen frequently, that when things do particularly go wrong with procedural sedation, they can go particularly wrong, and you really need to have all of your equipment ready. You need to have extra hands on standby. So this particular study was a systematic review looking at a little over 2,000 cases. There were 55, and that they looked at almost 10,000 procedural sedations. And from that, which those procedural sedations included randomized controlled trials and observation studies, this particular article made a chart of the most common adverse events. So particularly we're looking at is going to be anything that has opioid and midazolam included, and that this is so apnea is one I'd like you to draw your attention to, and that in every 1,000 procedural sedations that receive opioid and benzos, that there's approximately 12 cases of apnea in 1,000. And then draw your attention to the bradycardia adverse event, the hypotension adverse event, and the hypoxia. So hypoxia specifically up to 40 cases in every 1,000. Something that is worth noting. And then what some of your adverse emergency medical intervention adverse events would include aspiration, laryngospasms, and need for intubation. And then what wasn't included in this particular chart was allergic reactions. So reviewing our protocols for pain management, we have a couple options. Toradol, which is an NSAID, not to be given in trauma entries. Opioids, we have a couple, or we have fentanyl, and then we can use ketamine if we've met our opioid use treatment. Nitrous oxide, I'm not for sure if all agencies carry that, but I can see where there may have been confusion or interpretation of this protocol stating that facilitation for pain control could include Versed. In discussion with the MPD's office, we're going to remove that from the pain protocol section. That might be a big change for a lot of providers, especially because I don't think that, at least I wasn't aware of it being used in this way up until these two cases were brought to me by the ER physicians. Anybody have any questions, concerns, thoughts? All right. I believe Dr. Whitwer's on this call. Does he have anything more to say about that?
Jackie, I don't think Dr. Whitwer's on the call. He had an appointment this morning. I did want to mention, and thank you for this the detailed summary at the end. This was, and these are two sentinel cases that we have seen where combination of sedating and analgesia medications have created, difficult assessment issues upon arrival to the hospital, as well as hypotensive events. Just a note in that both of these cases, the treatment at the time was per protocol, but that combined with the other cases that I talked about have definitely opened our eyes to the use of sedating medications and analgesia at the same time, and it's definitely created some issue. I think that in the future, moving forward, managing pain is going to be much more clear now. And then using sedating medications is going to be, as you alluded to in the beginning, sedating medications for things like cardioversion and during the RSI sequence, post-intubation. That's going to be very clear now. So I think that, and I appreciate this discussion of making it much easier to make decision-making when dealing with pain as well as sedation.
Thank you, Mark.
Jackie, this is Cliff Free from Camas-Washougal. Oftentimes this cocktail is used in conjunction with muscular spasm, especially related to back pain patients. And historically it's been used. in the treatment of that condition as well, the idea of thinking that the Versed might reduce the spasm, which would reduce the pain. What's your recommendation in treatment of that injury pattern?
Well, so non-traumatic or at least non-broken bone back pain, I would say pick one or the other. And then, you know, if you're talking about non-traumatic, so these are your like
I am.
Sorry, these are like your sciatic complaints. You can do Toradol and fentanyl if you want, but I would not, I mean, even in my own practice and in speaking with our office and in Dr. Mock's practice, that we don't mix benzos and opioids in patients because of the fact that this oftentimes escalates their care, their need for potential airway protection. So I would say that if you have a patient that's non-traumatic back pain or complaints of spasms, you can have the option for a non-steroidal anti-inflammatory and a fentanyl option. If you do choose to say that, or if you do choose to go down the pathway of, I really think that these, so I guess I'm not sure if you're asking, are we taking away Versed or benzos or just back spasms? I think that if somebody really feels that the back spasms is the major issue going on, you can consider treating that only. And if it is removed out of our protocol for back spasms, then a call to base would be potentially warranted, or we can revisit if we want to treat just the spasms with just benzos, but I would recommend not mixing the two. And in the event that this is a traumatic case, you know, from MVC or a fall, I would say that I would really be especially if it's a trauma activation, NSAIDs are not on the table for those cases. So at that point, I would be maximizing pain control via narcotic or analgesia route. So doing fentanyl, and once you had multiple doses of fentanyl not responding, if that's the case, then considering pain dosing for ketamine.
Okay, so I'm hearing that the priority of interventions for non-traumatic spasm back pain would be to control the pain and essentially let the hospital sort out controlling the spasm.
Unless, I would say pick whatever the crews would pick what they think is the most problematic for the patient. Is it pain or spasms? And if it was spasms that seemed to be debilitating, then consideration of treating just the spasms, but not both at the same time.
Thank you.
Absolutely. So Jackie, one more question. The question was, any thoughts on using ketamine instead of Versed as a backup for patients not responding to opiates?
Yeah, I think it's in our protocol. Is that right? Let me go back to.
Yeah, that'd be helpful. Go back to the pain control page, because as you mentioned, the only change is going to be removal of B under facilitation.
Mm-hmm. So under ketamine, which is the right side, it says that you have to give at least 2 doses of opioids first. And I see a comment here in the comments saying that they had luck with ketamine previously in another system. And I have as well. If I feel like, I mean, personally, clinically in my own practice, if I am giving Toradol and Dilaudid and the patient is having not intractable pain, so can't control the pain, then I will consider giving ketamine earlier than 2 doses. And, you know, in our EMS protocol, it says you have to do at least 2 opioid doses first. And please remember that your opioid dosing is, so it's 50 microgram increments, but recognize that usually in IV administration, it's 1 microgram per kilogram. So most patients aren't 50 kilograms. So you have some room to actually get to the patient's potentially therapeutic range. So yeah, I mean, I think that pain is important to manage. Your experience with the patient, your patient's experience with you is greatly improved when the patient isn't screaming and agonizing discomfort. But I think that having to overshoot it by having to assist their ventilations is something that we should avoid.
So Jackie, one more question, this is one of those anomalous situations that is rather specific, but for agencies that are with patients for long periods of time, i.e. mountain rescue situations. The question is, can this protocol be modified? I think my answer to that would be use your pain medications as appropriate. And if you're still with the patient for another couple hours, that's a medical control consult to figure out what the best way to manage that is.
Yeah, I would agree. I would agree. I mean, those special circumstances we can't include in all of our protocols. So those special circumstances, as they don't occur all the time, maybe for some agencies they occur more frequently, but that'd be something to get some further guidance, especially if you are, looking at our opioid section. If you've given, up to 200 micrograms per hour already because your patient is 175 kilos, and you're finding that you still have another 2 hours or an hour before you get to the hospital, that's a good idea to contact medical control and get some idea of what to do if you're in that situation. And then for those that have never used ketamine that often, or that have not used ketamine for pain control, in speaking with Camas, I would make a couple points and for those that have used it, you can also add your own thoughts. But for me, I usually give the patient or the family member who's consenting to giving ketamine. So, but that would be like potentially, I don't think it applies here at all for us, but for pediatrics, for me in the hospital setting, yeah. So, anyways, is to get them an idea of what to expect. I tell them that this might make you feel like you're a little bit high or a little bit disconnected, that you feel like you're almost a little bit as euphoric or not quite in your own. A lot of patients feel uncomfortable when they feel that they don't have control of the situation, and that's kind of the same type of pre-warning that we do with adenosine. Hey, give you an idea that this may make you feel a little bit weird. You may not have ever felt like this before. That is a normal effect of this medicine potentially for you, so I don't want you to be alarmed. And that's that whole pre-warning that we do that helps that patient not feel like you're giving them something that they're having a reaction that no one else has ever had. If there is not any other questions, we'll move on to the other cases. Or any other thoughts? All right. I heard a beep, but I don't see anything new in the chat. All right. Oh, okay. So 64-year-old female. She was watching TV with her husband. She had sustained a syncopal episode, and that was what the contact for EMS was for. PPE was appropriate. The patient was awake. She was oriented, maybe a little bit confused, ANO times 2 or 3. Her airway was open and protecting. Her pulse was present. There was no signs of bleeding. Her initial vital signs are significant, only for some hypertension at 150/117, and that her history includes AFib, COPD, and pneumonia. The history provided was that she was watching TV with her husband, and that her husband noted that her breathing had become irregular. She was snoring, and he was unable to arouse her. She had about 20 seconds of seizure-like activity. The husband called 911, put her to the ground, or actually he did some bystander CPR while she was sitting in the chair, and that she woke up. The times, I tried to keep it all on one side, so I apologize if it's a little bit on the small, but the patient, after EMS arrival, they were looking for possible differential diagnoses for altered mental status and neuro complaints. So they checked a blood glucose, they checked a stroke assessment. She had another seizure lasting for approximately 2 minutes. An IV was placed. After her seizure, no pulse was identified, so they started CPR. They noted that they were unable to put an eye gel in because her jaw was clenched. They put her on the monitor, and identified this rhythm. The top one being the rhythm, and the bottom one here is when she was shocked. It does look a little twisting of the points or torsades here to me, but nonetheless, the treatment's the same, at least electrically. She was noted after being shocked, as you can even see in this image, that she went into a perfusing rhythm with a pulse. Her eyes were open. She had repeat vital signs, showed that she was a little hypertensive, but otherwise remarkably better, and that she was still obtunded with a GCS of 3. They opted to RSI her once they got out to the ambulance to protect her airway. There was mention in later documentation that the patient had motion that she was having a hard time breathing, but either way. They were able to intubate her with first pass success using video laryngoscopy, which I have an image of. And it looks like from watching this video that they loaded the ET tube on the Escherman, and as you can see it come into view on the bottom more right side of the screen. You can see the vallecula, or the vocal cords and arytenoids, and as they're working on getting and there's the epiglottis, which kind of sinks down, but they use the anatomy of that it should be just posterior, and then running the ET tube through the vocal cords while keeping the video laryngoscopy continuous until your cuff is past the vocal cords. They were able to get first pass success, which was fantastic. They put a HEPA filter on, and they proceeded to sedate her, post-intubation sedation with benzos. She was transported at 35 minutes from patient contact, in that they continued to reassess her, noting that her end-tidal CO2 was increasing. They felt that this was related to overbreathing, and they decided to paralyze her to optimize her hemodynamics, given that she was also becoming increasingly more hypotensive, and that allowed them to optimize her ventilation as well as give her some IV fluids, which improved her blood pressure, and was also able to help with her ventilation status, and continued with Versed throughout the encounter until hospital arrival. They did also get a post-ROSC 12 lead, and they repeated it to make sure that there was no changes to suggest a STEMI or any other arrhythmia. All right, so in review of this case, I thought that the pre-hospital care was awesome, in the sense that there was a rapid assessment for altered mental status and neurological differential diagnoses, that they managed her arrhythmia with defibrillation, and that they chose to RSI her once they were able to get her into a more secure area. It sounds like the documentation from the scene was that it was pretty crowded. She was a big woman, and that the chances of her having a tube dislodgement was high. They have all of their equipment, including video laryngoscopy as well as a bougie, in that their PPUs are appropriate, as well as the use of a HEPA filter, and that they not only got a 12 lead after getting ROS, but they obtained a couple to make sure that there was no change in her electrical or cardiac activity. Some of these rooms for improvement come from Dr. Whitwer. So post-intubation sedation without analgesia. Remember that we really in our protocol, it indicates that we should be using pain management first, so fentanyl, and then adding benzos or Versed as necessary to help facilitate patient sedation and also ventilation synchrony. And that he felt that it might have contributed to her overbreathing, in that given that they were coming in on a patient that was reported to have had bystander CPR, that why were benzos not brought in with her? Apparently they were unable to give benzos because it was locked and only the paramedic had the code for the compartment or the cabinet. And then why was there not a 4-lead EKG or 4-lead monitor placed early on, given the report that she had arrested? And he interpreted the rhythm as torsades. In the hospital, central line was placed or a central line was attempted, but the patient was noted to be awake and responding despite intubation. So they felt that there was no need to cool her since she appeared to be neurologically intact. She did get a CT scan of her head as well as a CT angio of her chest looking for a PE and a CT of her abdomen and pelvis. The only findings were significant for bilateral 2nd through 5th rib fractures attributed to her CPR, which just indicates really adequate CPR, really. She was noted to have QTC prolongation and some ventricular irritability, so she was started on a lidocaine drip and MAG bolus, and she had some hypotension requiring pressors. To her hospital course, she was extubated on hospital day 2. They felt that she was at risk for having another ventricular arrhythmia, so they placed an ICD on hospital day 4. They thought that her QTC prolongation was due to her dofetilide, which is a class 3 antiarrhythmic potassium channel blocker that she was given or administered for her AFib. They felt that prolonged her QTC, which put her at risk for having the ventricular irritability. Her longest QTC interval was 567, and that she was discharged on hospital day 7, fully neurologically intact. Review of our protocol here for pulseless VFib or VTAC, epi, amiodarone, MAG are your options, and if amiodarone's contraindicated, lidocaine. And reminder of when, so kind of focused up here to show you that if you interpreted that rhythm as being torsades, you really want to give them MAG as opposed to amiodarone, because the contraindications to amiodarone are for long QT syndrome, or if you suspect hyperthyroid, but that's wouldn't be fault of anybody in the pre-hospital setting, as it's not in our protocol. I believe and we only have 5 more minutes, so I'll save the rest of the questions till the end. So 77-year-old male found on the couch. His chief complaint was difficulty breathing. PPE by EMS was appropriate. It's a little bit unclear, but I believe that the patient was awake enough to call 911, and that he had reported that he thought he was having a heart attack again and was complaining of some chest pain, and that he apparently, from documentation, was noted to have his eyes roll back and become unresponsive. So that's why I document primary survey as that. For those that were on scene, if it was different, I apologize if I misrepresent you. Vital signs initially was noted for a heart rate of 40, and that his respiratory rate was 6, his GCS was 3, so I have to believe that that was after he was witnessed to go unresponsive, and that his past medical history included a non-specific cardiac problem, hypertension, high cholesterol, diabetes, and erectile dysfunction meds. So initially, the patient was noted to have a quick decline, and that he became unresponsive with agonal respirations. EMS had documented that they initiated pacing and started to assist his ventilations. This is what was indicated in the chart for his pacing, which this looks like VFib to me. So I would say abort pacing on that. An IO was placed, an iGel was placed, and he was defibrillated 10 minutes after patient contact at 200 joules. He was given a milligram of epi. He was defibrillated a second time, a third time. He received amiodarone and a milligram of epi, and he was defibrillated a 4th time, a 5th time. He got ACLS meds in between. He was defibrillated a 6th time. He had a definitive ET tube placed, given that he was not really turning around despite resuscitative efforts, and that medical control was called at 24 minutes from patient contact. Now, the report I was given by the ER doc who took this call, who also brought this up to our attention in the MPD's office, was that this call initially for medical control was for field pronouncement. And their concern was that this was a witness arrest in a shockable rhythm refractory to all treatment. So medical control had stated that they informed EMS to transport this patient and continue resuscitation. So, not to belabor, the patient was shocked 13 times before hospital arrival. He continued to be in VFib in all pulse checks, and he also received a couple more doses of epi as well as mag. All right, so in review, getting a SGA in right away and later consideration for an ET tube was perfect. Medical therapy management was in line with our protocol. Aggressive and persistent electrical therapy treatment was excellent. Like I mentioned, he was shocked 13 times. Where we can improve in peri-arrest, moving to CPR and ACLS is probably more effective than trying to get them to capture with pacing, especially because they're probably not perfusing very well, in that if we're going towards giving them meds, we should be augmenting their ability for cardiac output with CPR. And that a persistent shockable rhythm should prompt transport or at least medical control. I looked at our protocols. It doesn't necessarily say if you have persistent VFib or VTAC refractory to treatment that you would transport. It says if you've shocked more than 3 times that you should consider moving the pacer, the defibrillator pads. And then obviously consider repositioning defibrillator pads, and then don't forget to check a blood glucose even if it seems like it's all cardiac. In the emergency room, CPR was still in progress. The patient had a pulse check that showed VFib. He was shocked. He got another milligram of epi. Next pulse check, he had ROSC, and that was 53 minutes from EMS patient contact. Cath lab team was activated due to high risk or high concern for a possible cardiac event. The subsequent post-ROSC 12 lead showed a STEMI. He was started on epi and norepi before going to the cath lab. In the cath lab, he was noted to have a thrombosis of his previous stent in his RCA. He was acidotic and hypotensive, so he required both bicarb and vasopressors. Basically, he underwent cooling, and that they thought that his anticoagulation for his stent, which was Pradaxa, had failed him, so they switched him to Pradaxa and aspirin and started him on amiodarone, given his ventricular arrhythmia history from his cardiac arrest. And that during his hospital course, he also developed AFib, so they added rivaroxaban or anticoagulation to him as well. And he was discharged home on hospital day 7 with full neurological recovery. Of note, he arrested a month earlier to this event, where I was actually involved with his care, witnessed arrest on a bar stool at a bar with CPR and ACLS in progress when he arrived, and we were able to get ROSC back. So here's a very lucky individual who arrested in the pre-hospital setting outside the hospital with early CPR and ACLS and full neurological recoveries both times. So I'm going to run through this pretty quickly since it's 10 o'clock. So ventricular storm, it's when you have 3 or more sustained episodes of VTAC, VFib with shock in a 24-hour period. This guy met the criteria with 13 shocks. And this could be due to MI, structural heart disease, ICD, or inherited rhythmic syndrome, such as like QT, I think it's Longholm syndrome or the other QT prolongation syndromes. It usually has a pretty poor outcome, 7.4-fold higher risk of death than patients without electrical storm, in that if they have VFib as their electrical storm presentation, the mortality is upwards of 97%, and it's usually related to ischemia. You can have ventricular storm in patients that have ICD, although ICD's placed, although it's uncommon. I guess you can determine what uncommon is, 10 to 20%. So in management of ventricular storm, just like our protocols state, amiodarone, mag, lidocaine, consider reversible causes. Reversible causes would include, is the patient having an MI? Is there an electrolyte abnormality? Are they in decompensated heart failure? Is there sepsis going on? Amongst a couple other things. And then consider changing the defibrillator pad placement So in this review of our protocol, if the patient, the EMS did a great job with medical management. The only other thing is that if there's persistent VFib or VTAC, consider repositioning from AP to maybe, anterior and lateral. All right, so this is a short summary of what we covered in the last hour. Inferior MIs get a V3 and V4R review. Remember the KPIs for STEMIs. We should be managing pain with analgesia and analgesia meds. Sedation is relegated to cardioversion, CPAP, excited delirium, RSI, and post-intubation sedation. Video laryngoscopy has ability for you to have a really good view, even if you couldn't necessarily get the same view just looking through their mouth. And it gives us a great opportunity to look at QA. And then ventricular storm management, make sure you consider all your medical management and consider moving the pacer pads or the defibrillator pads. And if you have persistent electrical storm, really should consider medical control or transport. I know that we're in the pandemic world of if we have a patient in cardiac arrest that doesn't have pulses, that we should be really cognizant of not transporting. I believe, Mark, you can speak to the most recent version of our pandemic protocol. Does it leave room for persistent ventricular storm?
No, that's something that we might want to talk about moving forward with this. One of the things that we've noticed with especially cardiac arrest management in the COVID environment is maintaining appropriate PPE and some getting to the patient. I guess the take-home message is make sure that your PPE is appropriate and you manage that first prior to managing the patient. As far as a ventricular storm situation, that's something that I think we need to approach as we move forward with this, or look at and revise the protocol.
Those are good points. All right, if anyone has any questions or concerns, please bring them up. Otherwise, thank you guys for your attention and your time. I hope you learned something. I hope it was beneficial, and I hope you have a great Thanksgiving holiday.
Thanks, Jackie. This was an excellent discussion today.
Awesome.
And happy Thanksgiving, everyone.
All right.